and I have a question, and that's who the heck's managing the medications here? And the answer that she got back was a little bit shocking. And for a pediatric pharmacist, like, she didn't really understand, one, how limited of a resource she was, how specialized this group of people really are, and what's happening outside of acute care, outside of the hospital. And the answer to that question was they had a pharmacist that was really just kind of checking the regulatory compliance boxes and not working up the patients, right? And so she said, I'll come in and you can pay me whatever you're paying the other person. I'm going to open the charts. I'm going to go in between all of the prescribers and the doctors and the nurses and everybody here, just like I do in the hospital. And I'm going to help fine tune these therapies and make sure that patients are getting the right, or at least the best therapy for them individually. We're selling something, it's free to them. It's on behalf of their health plan. It's a benefit that their health plan probably didn't tell them about when they enrolled, but they have available now. We have to reset that what their concept of pharmacy is comprehensively, and then get them to agree to meet with us the next time we have a call, and put them on video and then align them to a single pediatric pharmacist and the nurses and technicians that we have supporting that role.
Do you have your own clinical staff, like pharmacists and clinical staff that communicate with these families that essentially join those calls and help kind of understand, like, what are all the things that your kid's on? Okay, this is right, this is wrong, this could be better. Does it work kind of like that?
Exclusively.
Okay.
Yeah. "31% of pediatric prescriptions contain an error. It's 3 times the rate of adults, and that's a really good source." 2023 research out of the Medication Errors Report by the U.S. Pharmacopoeia states 31%. We think it might be higher, or like at least non-optimized prescriptions. A lot of this is rooted in something as simple and silly as the fact that pediatric medications are dosed based on weight. And if you're a parent or you've ever seen a prescription or you've taken in a child's prescription to the pharmacy, guess what's not on that? The weight. So we see, in our own kids, my kids, Jenna's kids, our CEO, like, oftentimes the indication for the drug does not match up with what the dose was. And there's no check at the pharmacy. It just gets filled. We'll start to look at what's been ordered, what's been picked up, and what's been left there. We'll connect to health information exchanges and the national networks that house lots of clinical data through what's called a QHIN. There was recent legislation passed over the last few years to make access to treatment information a little bit more easy for us providers. We leverage all of those new regulations through this QHIN and an act called TEFCA to get as much as we can beforehand. And we've got a good idea of where we might start to make adjustments based on the subjective assessment and kind of what we get from the patient before we ever meet with them. But the immediate thing, I think, for patients and parents is a resource. So when they end up in the ER that night unexpectedly, or they've got a cold, but something, they've got all these other things going on, and they're in the middle of the aisle at CVS or Walgreens, they've got somebody to reach out to and be like, hey, what do I do? The parents of the kids that we're working with, if the kid is, even if they're a few years old, they've been through a lot.
Mm-hmm.
They're typically reluctant to let somebody new or something new onto the care team, right? And so in these initial outreach calls, we get a lot of objections. There's like, hey, we've got everything under control. I've been doing this for 12 years with my son, right? Like, I don't need this. I've got it. Oftentimes, we'll have to say something like, will you just give us a shot? Can you show up on video for 5 minutes? And if you don't think that it's going to provide anything for you, go ahead and hang up. Like, you don't have to do this. It's your health plan. This isn't a check for prior authorizations with your health plan. Like, we're going to work on your behalf and really just try to help you clinically. If you don't find that, then you don't have to come back. So outside of the deprescribing, just the fine tuning of things, they stop admissions from the skilled nursing and subacute rehab into the hospital, which is really important to those businesses to keep patients there and not, nobody wants a kid or any patient to get sick, but like, they also want that patient to stay with them. And so she kept them from being admitted to the hospital. From benchmark pre-implementing the solution to just 9 months later, they had reduced the admissions to the hospital by 44%.
That's a huge number.
Wow. 44%.
And that, equates to cost, right? Which is something we talk about a lot in the healthcare industry is, these unnecessary visits to like ER, ICU. So avoiding those, that's a big cost savings as well.
And all the drugs they don't have to take now because they were taking the wrong drugs.
And just healthier, right?
Yeah.
Well, better cared for children.
This has been a Shut Up production.